All right, let's talk about some, these are kind of more clinical post-operative stuff. I find patients are surprised about how long the pain lingers after surgery. What do you think contributes to some people having pain for months after surgery versus some are kind of like, it's comes and goes in 4 or 5 weeks?
That's a curious phenomenon.
Okay.
I mean, I've got people that took very little pain medication. Other people needed a lot longer. That's a great question. I don't know. I do think that in the recovery, if we had some way to reduce swelling,
Yep.
I think swelling is the key. And I think there are a lot of lymphatics around the knee. You got veins that bring the blood back, but the lymphatic system brings fluid back to your heart through the extremities. And I think that we underestimate the amount of lymphedema that occurs with knee replacement. And nobody really, when you see a full-blown case of what we call lymphedema, it's really shocking. But I think there's a lot of subacute or lymphedema that we don't really manage well or know how to manage. That if we could ever figure that piece of the puzzle out, which translates to reducing swelling, I think your recovery is going to be much faster.
I 100% agree, because the swelling is the stiffness and the pain.
Yes, and pain. It's a painful operation. I'll be the first to say. Now, there are a lot of things we do, which we can touch on later, to help with the pain and with this multimodal pain management and nerve blocks and things. I mean, we do a much better job than when I first started, no question about it. But it's an invasive procedure, and it's going to hurt. So,
no, I agree. And again, I feel like as a therapist, we usually focus on exercises, meaning just basic exercises. And what I've learned since specializing in these things like isometrics, what's called contract and relaxing, helps muscle pumping, helps reduce swelling. I feel like we as therapists don't do enough education on what elevation actually looks like to reduce swelling. I think we overutilize ice later on, thinking it's going to reduce swelling, and I think it impedes the body's natural inflammatory response, which I'm on a soapbox there because I've been reading a lot of research. And I also think diet. We don't talk to patients about diet, meaning PTs don't. We're so focused on the exercise, but there are foods that increase inflammation in the body, and I think all of that can make a difference. Anyways, I feel like we PTs, you hand them over to us, and we're so focused on the exercise component that if we could step back, instead of me cranking on a knee and trying to increase flexion, if I can teach this person how to control swelling from now until my visit 3 days from now, that might be more impactful than trying to bend their knee today.
Yeah, I mean, everybody focuses on range of motion, which is critical, of course, but
it will come.
Whether or not you should reach a certain degree by a certain point in time, I don't know. I'm more interested in progression, and some people get their motion back quickly, some are a little slow, but as long as you're progressing, I'm usually willing to be patient.
I agree.
Because I think there are a lot of factors that go into why people are stiff or not, but I do think swelling is a huge issue that is not well treated. And maybe we just don't know how. Maybe.
There's a surgeon, Dr. Andrew Wickline, who wrote an article about the tsunami of postoperative swelling, and I dove deep into that. And part of me really made me realize that I'm doing the patient an injustice if I have techniques. As a PT, we have techniques in terms of manual techniques, massage techniques, taping techniques, and I wonder why it's not just a standard of PT practice to do those things to control swelling.
Yeah, and I agree, and I don't really know the answer. I do know that there are, some lymphedema pumps and things like that we don't use these routinely. Do we? Should we? Maybe so.
Maybe.
I think if I had a knee replacement, I'd be looking at a device that does cooling and
compression and circulation.
And how come we don't use it every time? Nobody wants to pay for it.
Right.
So
no, I agree with you.
We'll
talk about the ideal.
We can talk about all that later.
We'll talk about the ideal knee replacement recovery. When I have one and when you have one, we're going to talk about what we would do.
Just the technology and all that, but Yes.
So is there, now since we're talking about swelling, is there a rhyme or reason why someone's leg just balloons up and other people's doesn't?
No. I don't know that answer.
Either.
I don't either. I don't know that. I mean, the one thing that does drive us crazy are people that are on anticoagulants, and there's a lot of the population takes blood thinners for things like atrial fibrillation, and they're on these blood thinners. And one of the risks of a knee replacement is deep vein thrombosis, but the real risk that we want to reduce is a pulmonary embolus that can be a fatal complication. So blood thinners, we use blood thinners after surgery routinely on everybody, but the people that are on the more aggressive blood thinners, if they bleed into their knee, it's a disaster. And so you're kind of walking this fine line of making sure we don't have a major complication and trying to avoid a bleed, which bleeds are bad. And so
ouch. And that probably goes along with, because again, I'll have some patients, they said, why do some patients' legs bruise all the way up to their thigh and then some have minimal bruising? Again, I know the anticoagulation thing, but is there any other reason that you can think?
I don't know that answer either. And, there is a debate about tourniquet or not.
Yeah, tourniquet. I was going to ask you that. Yeah.
If you look at the studies, the results are the same.
Right.
And there are people that feel strongly that not using a tourniquet reduces pain, swelling. I don't know. I can tell you that doing a knee replacement where you can see really well and there's not blood everywhere is pretty nice. And I used a tourniquet. I would continue using a tourniquet. I was very comfortable with that concept. We've tried to keep our tourniquet times as minimum, but there's no convincing evidence that one or the other makes a difference.
Yeah, I've read that too.
So I don't know.
And I think, like you said, surgeons have preference. Some are like, I want to have a clean field. I want to see and know what I'm doing, and be as efficient as possible.
And people that, in terms of blood loss, knee replacement, blood loss is really not much of an issue at all. People that don't use a tourniquet are definitely going to lose more blood, whether or not it gets to be clinically significant, maybe not, but
interesting.
Not a big issue.
Okay. And then is there something that you have seen in follow-up visits after you've done a surgery or while you're doing a surgery? Are you like, this one's going to have more trouble with bending, or this one's going to have more trouble getting that knee fully straight? Do you have an impression of that during the surgical process?
Well, maybe not during the surgery, but you can, but mostly it's their preoperative range of motion. So a stiff knee before surgery tends to be a stiffer knee after surgery as a rule. Okay. And on the flip side of that, though, is the people that can have hyperflexion, they can flex like 140 degrees. They're not going to get that back after surgery, but they don't need that. But I try to be sure and tell people, if you can bend your knee and touch your rear end with your foot, you won't do it after I get finished. But I don't think that should affect your function.
No, right. I mean, 125, you're good. You don't need 140,
so,
but
you need, most people need probably 110 degrees of flexion to perform activities of daily living. We certainly want to get full extension if we can, because that affects your ability to walk and your strength and how much effort it takes to walk. So
I agree. Well, and I'll tell you, I feel like that's a great surgeon response. As a PT, 110, like I said, baseline, I want you to have a cushion, because like you alluded to earlier, people kind of regress a little bit. They lose 5 to 7 degrees, 3 to 6 months later, because they've eased up on the aggressiveness of the exercises. So I like to target like 120, because then if you regress to 115, you can do everything you need to functionally. But these younger patients are like, I want to be able to do child's pose. And I want to, and so again,
well, that gets back to expectations and what are you going to really accomplish by doing this operation? And I say 110, we shoot for 120 plus. I think if people have a goal, that's a good thing. They don't quite get there and they come to the office and, I got 113 a week ago, I'm 117 today. Okay, big deal. The point being is that if you don't get so-called ideal range of motion, whatever that is, as long as you get enough to be functional, that's not so bad.
That's right.
Yeah.
And
but
as
we shoot for as best as possible.
Of course. And like I said, to me, as long as someone keeps gaining, we're going to keep going to see what we can get out of that knee. But I do think PTs kind of plant the seed of a number for the patient, and we should stop doing that.
Yeah. Well, because then they're disappointed in themselves that they haven't gotten there. And then, like I said, there's a lot of factors that go into it: a deformity, how much motion they have to begin with, previous surgeries, et cetera, et cetera. But,
well, and that leads me to varus versus valgus. So varus being bow-legged, valgus meaning knock-kneed. Do you find that when one or the other comes into the surgery, you can expect something like, is one better than the other, have a better outcome than the other, or they're just, it's irrelevant? Just to level it.
I don't know that I can say that. I mean, we probably 90% of knees that you replace are varus knees, and they get great results. Valgus knees, knock knees, are harder to deal with. It's sort of technically a more difficult operation, and so there's probably greater risk for not getting quite as good a result as you might get with a varus knee. On the other hand, I can tell you that, and a lot of valgus knees are women for some reason, but I can tell you when somebody has a really severe valgus knee and you correct that, they are so happy.
They are.
And they are very happy.
Well, and I'll tell you, I see them and they're like, look how straight this leg is. And then they're like, wow, look how crooked my other leg is. And so, I mean, if it's bilateral, but it's true. It's true. Okay.
I always thought valgus knees were fun because they're a little more challenging, but patient satisfaction was pretty darn high.
Makes a big difference. And we kind of talked about, because I want to kind of focus on some post-operative questions, the PT part of it. Like, so are you, because your career has seen the span of total hips that, went to inpatient rehab, right? And they went to skilled nursing and they got the 6 days a week, and now total hips are like, you go home and you sometimes don't get any therapy, right? So there's So there's been a transition of that. So what's your opinion? Because I'm in the knee replacement space. I don't do hips, I do knees. What is your opinion on, is physical therapy a must? And I'm gonna answer this very specifically. Is physical therapy it will never, in your opinion, not be needed for knees, or is it that the patient has to do something? And if they will do that on their own, then maybe they don't need PT, or you're like, no, knees and hips are different. Hips are fine. They'll get okay. They'll do good enough without PT, but knees are not like that. What's your opinion?
Well, a lot of hip replacements will kind of self-rehab.
They do.
As they get back to activities of daily living. Now, I do think there are a lot of people that benefit from therapy with a total hip. So don't get me wrong that you don't need therapy, but there are a lot of people that really don't need it. And they're happy. Now, a knee replacement's a completely different situation, and rehab therapy after a knee replacement is essential to getting the job done. And there are a lot of interesting developments, and with mobile apps, and can you do this on your own, or can you do it in conjunction with a therapist, and a app of which I've had virtually no experience with in my career, but it was all starting to happen when I retired. And it's kind of interesting stuff, because if it motivates a patient to do the exercises, but they have to do it the correct way.
Correct.
And it's like lifting weights. You don't get the result if you're not doing it with the correct technique. And so it's all kind of an interesting thing in the future, because it all, not to totally change the subject, but a lot of this, everybody's focused on cost, which we can talk about more in technology. But so how do you get the cost down and still get the result? But the therapy, you got to have it.
Well, and the only thing I'm going to add to that is I am shifting in my thoughts, because again, I'm a PT. And so in my head, I fought the hips. I'm like, the hips need to come to me. I need to do some glutes training. Like I need to do some stuff training, because an arthritic hip had weakness prior to going into the surgery. Let me show them how to quickly do that. But I take my words back. A lot of hip patients I've talked to have self-rehabilitated through return to function. Okay.
It tends to be a more low demand patient, and they do pretty good. But there's no question with a total hip, you're going to get more benefit if you get on some hip abduction exercises and things like that. There are things you can do to absolutely improve a patient's function. So,
and what I now am learning about knees, because again, I used to think my hands-on skills were invaluable. But as I've gotten older and heard back from patients, I also realized that my hands on their knees cause a level of anxiety and fear to some patients. Some love it, some hate it. And I needed to adapt to the ones that didn't like me putting my hands on their knees and doing education. And I've learned now through education, if I can teach that patient how to fish, they feed themselves for a lifetime. I think my old Shella used to be, I didn't realize I was making the patient very reliant on me, my skills, my modalities, my techniques, and then I'd send them home. And it worked fine when therapy was 6 days a week. And it, but then when it went to 3 days a week or 2 days a week, all of a sudden, that wasn't enough for them to, in my opinion, I needed to teach them something to do every single day, not just twice a week when they were with me. I felt like the home exercise program was a little archaic and basic, and then they'd come to me and I'd do something really advanced and good, and then you'd send them home for 2 days, and then they'd come back and we're just constantly playing catch up. So I've really worked hard in the last few years of figuring out what I can tell the patient to do at home multiple times per day to keep that progress going, so that we're not seeing regressions every time they come to PT.
Well, like I said, it's it's a painful operation.
Oh,
your knee is superficial. You get swelling, you get stiffness. You don't want to bend it because it hurts.
Yeah.
And what I really tended to really dislike when a patient came back and told me that their therapist pushed hard to make them bend their knee. I don't want to hear that, because all that does is create more anxiety and more pain. And
swelling.
So the therapist needs to be a coach. I'm not a therapist. I don't really know exactly what you guys do.
We can be too aggressive.
But I think that kind of aggressive approach is not helpful.
No. And again, I do better now, but in my prior years, I would have wanted to write a report to Dr. Schell to say that Miss Jones, her range increased from 85 degrees to 109. I want to, it's like a badge of honor for me.
Well, it's like you just got yourself a good grade.
Yeah, exactly. At the expense of. So I now know better. And Miss Jones would rather get that 108 degrees without being cranked on. But anyways, I learn and I do better. Okay, let's talk about surgeons and their variations. What I've learned through talking to patients and surgeons all over the US and actually all over the world, skills are different, techniques are different. I mean, outcome expectations are different. And you and I were talking a little earlier about some doctors have protocols of wearing a knee brace. Some have protocols you can only bend it so far in the first 2 weeks. Some say you can only do this. Some say, there's such a variation. Do you have is it just based on training? Is it based on insurance? Is it based on the office that you work in and what the protocols have been established? Because as a patient, they're so different.
Yeah, I think a lot of that is just probably where you trained and what you grew up learning. And some people never change. Some people will adopt new techniques. But I think a lot of that's just, this is the way we do it and this is the way it's been done. And probably there's a lot of reasons why people do what they do.
So they learn a technique from a mentor, a school, or whatever, and then it's kind of like the technique they take with them.
Right. And, some of us, or some people just turn the patient loose to the therapist. And if you have a therapist that you know and you trust and that you work with, that may work great. I tended to be more, do what you can do, but at the same time, you don't want patients overdoing it, especially early on, because you want to reduce swelling and elevation, and all those things are important. So I was never so much of, you can't do this, but you don't want to do anything that sets you back. And there's different phases of rehab of what you can or shouldn't do,
No, I agree. And like I said, I feel like in the last 5 years, the people that overdid it tended to overdo it with therapy, meaning the PT was present when they overdid it. They rarely overdid it at home on their own unless they had an incident.
That's probably true. And so it's a process, and it doesn't happen overnight.
So I have patients ask me all the time, this is why I'm asking this, and I have an opinion on this. They're like, I need to choose a surgeon that does this technique or use this brand or this, they have robotics, or I feel like marketing to patients, to the consumer, is getting crazy, right?
Oh,
All these implant manufacturers are doing a great job. And so patients will call and they'll be like, yeah, I'm trying to find a surgeon that does this, 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 and this. And I find that so interesting. What is your response to that?
Well, there's been a lot of marketing over the years for different implants, different techniques. I'll give you an example. One of the companies came out years ago with the female knee, women's knee.
Gender specific.
Gender specific. Where does this come from? Well, if you look at the stats, that the vast majority of, we're 60, maybe I think 65% of knee replacements are women. Well, great. I mean, hey, I've got a knee replacement for you. Well, what that really boiled down to that we saw is that size and how it fits probably does make a difference, but to call it the women's knee, but that's why these things happen. The robots, let me back up. The key to getting a good result for a knee replacement is putting it in well. And your instrumentation and your skill have historically what has allowed us to do that. So going forward, all this technology, I think it's going to make great sense. I think it's going to allow people to be more consistent in getting the best possible job done. And I think that we don't have the full answer yet. You got the robot, you've got what's called computer navigation, and I diddled with that for a while, dabbled in that for a while. I think it's still evolving. And we have these patient-specific needs, which I kind of found to be very interesting, and did a number of those in my practice, which is sort of the combination of navigation, because you develop this set of instruments that allowed you to put the knee in very precisely, which is the key to getting a good result. But in addition to that, it used a little bit different component design, so-called kinematics. Can we make a component or prosthesis that functions better? And that to me is the future of all this, is how you put it in, which I think ultimately is going to be more of a robotic technique as the technology evolves, and then maybe different components which function differently. Here's an example. The typical knee replacement does not mimic normal knee mechanics. And they work well, but they don't mimic normal knee mechanics. When we bend our knee in a normal knee, your femur slides back on your tibia. And knee replacements historically do the opposite. Your femur slides forward on the tibia. It's called paradoxical motion, which most of the time is not a problem, but for instance, it reduces the effectiveness of your quadricep strength. So getting in and out of a chair, climbing steps, your knee is not going to be as efficient as a normal knee with a knee replacement unless we start correcting those problems. Does that make sense?
It does.
And I think that's where component design and technology is going to make the operation better and for function and patient satisfaction.
So why is it that the implant companies haven't figured out a way to put it in so that the femur slides the way it does in the normal knee?
Well, it just has to do with and I'm not an expert on all this type of stuff,
but
it just has to do with what the components that we can make will allow your body to do. And because the knee has to be stable, it has to fit well, and there's a lot of factors that go into that. And that's where I think the navigation or the patient-specific needs or the robots are going to improve the ability to put these things in as best as possible. So it's going to be putting them in well as maybe some changes in component design that will make them function better.
Yeah. I love that.
I think that's the future.
Well, and I think that's great. And I'll tell you, the answer I give when people ask me, what if robotic this is this, my answer is, and I feel like you need to call me on BS if this is not true, but my answer is, I would find a surgeon who has done a high volume of whatever technique he has done whatever implant he is comfortable with, and he's been doing it for a long time, because that is going to trump a brand new robot, a brand new technique, a brand new whatever.
I think that's the perfect answer. If you look at the data that's available now and people that are experienced, high volume surgeons, the results are just as good with conventional instrumentation as robots. Is that going to change over the years? You're going to get a new generation of orthopedic surgeons that are trained on the robot that didn't exist when I came along, and they're probably going to get to be pretty dependent on it, and that's not a bad thing. So, but I think ultimately it's going to head down that pathway. Now, the problem with all that is nobody wants to pay for new technology.
It's expensive,
and that's where the fight's going to occur.
Well, and I'm not, and I'm going to say that again, I've been digging into all aspects of knee replacements, and what I've learned is once you make that financial commitment to get a robot and you spent millions of dollars and all this, then you're going to promote it. You're going to tell people,
sure you are,
because you have to get that the client. You know, it's a business.
There was a robot out there, and it's been there for years, and it sat in many a hospital collecting dust, and then about 5 or 6 years ago, it just came back on the scene, and great marketing. But anyway, but
I agree. Like I said, I think it's something. Some of the things are amazing, but it's the person who's working on your knee. What is their experience level? What have they done? Like I said, I'm an old school PT too, and some of these people coming out of school, they're learning things that I never learned, or I had to learn after the fact in extra courses, whatever. But I also think that's, this is my analogy of robotics, and the more you automate things, it's like I have a daughter that just turned 16, right? She just got her driver's license. She will never know to reverse by putting her arm back and looking and checking the rear view. I mean, she's supposed to, but because she's got a big screen,
she's got a camera on the back,
that has yellow lines and beeps if she's going anything. So she just looks straight when she's reversing. She doesn't understand this concept of, so I feel like that's...
Well, technology is good. Technology is going to evolve, and we need to take advantage of it.
Right.
But, I don't think we're quite there.
Right. Well, and as my daughter says, well, I don't have to do that, Mom. I can use this. And I'm like, that's fair. So I guess you'll always have a car that has a rear cam. So anyways, all right. So this is also a question I get from patients is like, how do surgeons select an implant manufacturer, like the design that they're going to use? Because is it true that surgeons usually use one or two brands and then they kind of use that, whatever? Is it a decision made individually by surgeons? Is it made by the institution that they work at because it's contracted with people above, or how does that work?
It's mostly by us, and a lot of it depends on where you trained. You may have trained on one or two systems that at your institution, and so you're very comfortable with that, and that's what you do. Some of us may change over time as we see new products come along and try to evaluate it and make sure that it does in our hands what we think it should do. And there have been pushes by institutions, again, cost control, to force us into using certain parts that didn't go over very well. Most of us are not willing to be pushed into something that we don't want to do, but there is some. I mean, the institutions negotiate prices, and so we're cognizant of that, and it's to our advantage to be price conscious as well. It's a long story, but we're not going to use cheap stuff because it's cheaper,
right?
And it's just, it doesn't work that way. And basically, all the there's a lot of implants out there that are. There's not a huge difference between them. They're all very good. These companies are good. So,
do you have an opinion? Do you have like top 3 implants you've seen in your career, or top 3 implants you've used in your career?
I mean, there have been a lot of evolution over time with certain companies, and so you might end up using one company's implant over another. I'm not really interested in naming names right now, if you don't mind.
No, that's fine. That's fine.
But there's a lot of good stuff out there.
Well, and that's what my research has yielded too. Like 20 years ago, it might have made a difference. 30 years ago, they're all leveling the playing field.
I mean, the technology of implant design and function has gotten
huge.
Materials, I mean, so again, getting back to why were we doing these in the older crowd? Well, they were going to wear out.
Yes.
And which was a significant part of revisions. Why do you have to revise these things so they wear out? We're not seeing much of that anymore. It's still a concern particularly it's a big concern in the younger patient, but the materials are so much better.
Lasting longer
than what we had.
No,
when
I agree.
Started.
I agree. All right. And then what about we kind of talked about techniques and surgeons, there's so many different anesthesia options, right? Why is it why has there not been this is the secret cocktail for the most effective pain management, for a knee replacement patient? Why is that not so? It's so spread out.
That has evolved over time. There's always been the argument of general versus spinal block anesthesia. I think most of us have always really liked regional anesthesia, spinal block anesthesia. It kind of depends on probably where you trained and your anesthesia support. But our improvement in anesthesia technique and pain management, which go hand in hand, has made a huge difference. We're doing knee replacements as an outpatient. If you told me 10 years ago I would be doing outpatient knee replacements, I said, no way. I mean, when I first started, they stayed in the hospital a week. A lot of them went to inpatient rehab. So then we got it down to 3 days, and I thought, this is amazing. And even my very old patients with medical issues, majority of them went home the next day. And probably could have been done as an outpatient, but it wasn't that long ago that Medicare would not allow you to do an outpatient knee replacement.
Correct.
And so it wasn't an option, but you were sending them home within 24 hours and they were doing great. So, but that's since changed. So peripheral nerve blocks for immediate post-op pain control have been hugely successful in alleviating pain. And we use what's called an adductor canal block. Initially, we started out with femoral nerve blocks, but the problem with the femoral nerve block is it paralyzed your quadriceps, and so they couldn't walk unless you put them in a knee immobilizer because their knee would buckle and they would fall, and that would be a really bad day. So as we got to the adductor canal block, which was an injection in your thigh, that along with the intra-articular local anesthetics, and there's different combinations that people are settling in on, but they've been super effective for that immediate pain control, which is really critical. Because if the people wake up and they're hurting like crazy, you're off to a bad start. It's a very bad start. And so if you can get them through the first 24 hours very comfortably, that's a huge win. Then we've gone to what's called multimodal pain management, where we've learned that, narcotics have a lot of side effects. And some of us joke that one of the side effects of narcotics is that they may reduce pain, but they have a lot of side effects that are not good. And so if we can reduce the use of narcotics and get good pain relief, that's huge. And anti-inflammatory drugs, which Celebrex, Motrin, Toradol, a lot of different stuff we use, have been really significant game changers. Ice, those type of things. So. And they've been very successful. I mean, the amount of narcotics we use nowadays for joint replacement is significantly less than what I did even 5 years ago. And with good results and patient satisfaction. So
no, I agree. I've seen a huge difference in it. Well, good, because obviously everybody cares about pain. All right, tell me, what are your thoughts on MUAs, manipulations under anesthesia? I hear so much about it. I feel like people are like, why do some people need it? Some people don't. Is it the patient? Is it, do you think that it's a surgical technique that surgeons use to improve patient outcomes and satisfaction? Or is it I don't know.
I don't think what we do, if I'm getting your question right, affects the risk of manipulation under anesthesia. Some people are just stiffer, and they for whatever reason they can't get their motion back, and sometimes we don't know. There is a condition called arthrofibrosis, which is fortunately very rare, and it's a disaster. But that's not something you can make that diagnosis till late in the game, when there are rare people who just stiffen up, and it's just a horrible problem. But as far as manipulation under anesthesia, if you reach that point in your therapy, your rehab, where you just can't make any progress, and you're frustrated, your therapist is frustrated, then I'm frustrated, and usually it's between 6 and 12 weeks that this comes into play, and then it's basically a decision by me, the surgeon, that, look, I don't think we're going to make any progress, and I think we ought to do this. There's not an absolute definitive set of rules as to, you need to do this. Some surgeons have looked on manipulation as a failure, and they don't want to do it because we sort of get graded. And if you have a high rate of manipulation, you were kind of looked at as, what's wrong with your patients? And I think that's the wrong way to look at it. I think manipulations, in my experience, were not very common, but I never hesitated to do it. I never regretted doing one on somebody I thought needed it.
Perfect.
And on the other hand, if people were making, even though it's 6 weeks, they were stiffer than you'd like, but they were making progress every week. You might see them, follow them a little bit more closely. And next thing you know, they started progressing pretty quickly, and great, being patient is good. But you get up to about that 12-week mark, and they hadn't gotten it. Manipulation after that, to me, never made a huge amount of sense, because what you're doing is you're breaking loose scar tissue, and if that scar tissue is going to get thicker and tighter as time goes on. So that was kind of my take on manipulations.
I think a PT's take on it is, like you said, if you're not seeing any change in their range of motion, to me, if a whole 7 days goes by and I haven't seen an improvement, and worse yet, a regression, which, that's what I hear from people. That to me is something to be concerned about. And like I said, but I also think as PTs, we don't change what we're doing if it's not working. And I think sometimes we need to change what we're doing if it's not working. Like you just said, maybe instead of exercises, there needs to be a focus on edema control, or maybe there needs to be a focus on something else. We need to change what we're doing. So if any PTs are listening to this, and your patient's not progressing over a 7-day period, the first thing you should look at is yourself and what you're doing and what you're having the patient do at home. I think that sometimes we don't do that. We think it's a passive, I guess they're not doing what they're supposed to be doing at home, and I don't know what else to do. We'll check it again next week, and then we'll contact the doctor if 3 weeks has gone by and the range of motion is still at 90 degrees or something like that. But,
and manipulation, like I said, it's a little bit later in the recovery. I mean, when they come in at 2 weeks and they're still I'm like you get 6 to 8 weeks and think, okay, are we really making progress here or not? And then that's when you start planning
really
the idea.
Worried about
and
it.
Patients don't like to hear this. They don't like to hear it, but I'll plant the idea.
Yes.
Not to scare them into doing things,
motivation.
but just that this is not a bad thing.
No.
This could be a very good thing for you. So, because they're like,
Yeah, I had a patient of yours a couple of years ago, same thing. She was progressing, but like I said, you just educated her on it. And it was enough for her to be like, it was so funny. She did a great job. What is your things on, again, surgical techniques, and you can just do quick rapid fire, like cemented versus non-cemented?
Cemented knees have been the gold standard, continue to be the gold standard. Cemented hip replacements are hardly ever done anymore. Right. They're done in people with poor quality bone, but press fit or cementless hips are absolutely the gold standard. Nothing wrong with cement in a hip, but with knees, it's a different set of mechanics. It's a different set of forces, and cementless knees, which means you don't use bone cement, where you get biologic ingrowth of the bone into the components. They're beginning to be much more popular. And I think there's some pretty good evidence that they may be, you've got to be sure they're just as good as cemented knees in terms of their initial result. You know, if the 2 or 5 year failure is higher, then you shouldn't be doing these things. I'm taking a lot of time to answer this question.
No, I love it.
I love the idea of doing away with bone cement, but it has to be the right patient bone quality. It has to be the right component. Some of the cementless knees are a lot better than others in terms of how they're designed and how they work. But I think it's for that 50-year-old crowd and for that larger crowd, avoiding bone cement, which eventually will break down and potentially can fail. If you can get biologic fixation and it works, I think it makes great sense.
And the big buzz thing right now is quad sparing. What is like?
Well, yeah. So the incision that you make in the big picture and the full recovery and the long-term results, you got to be able to see what you're doing. And so if you use a mini incision and you put the joint in badly, you've not done a good job. If you use a bigger incision and you put it in well, that's a better option. Most of us try to avoid making an incision into the quadriceps tendon or muscle. If you need to, you should. And if you're a big, heavy, muscular person, I didn't hesitate, because it's not going to make any difference in the long run. It may affect the immediate recovery some, but in the big picture, I don't think it's that important. There is an incision where you call it subvastus incision, where you actually kind of go lower and you kind of scoot the whole quadriceps extension mechanism over. And for a little skinny lady, it's a reasonable thing to do if you're good at it. But again, in the big picture, I don't know that it makes a lot of difference. It may make a difference in how quickly you recover, but what we're after is a durable result, and how you do the first couple of months versus the next 20 years.
Right.
Yeah.
That's what they care about.
Yeah.
Well, and I'm also, as a PT, I used to see just the incision that went, the long incision.
Yeah.
They're now doing, the side incision. And so there's a big old round. Yeah, I know. Just
I don't know that it makes a lot of difference.
Okay.
So.
Okay. And then some have asked me, why do some surgeons use staples and why do some use glue? I feel like it's transitioning more towards glue, but.
Well, I'm a big believer in a watertight incision. If you have an incision that leaks fluid, if anything's coming out, something can maybe come in. Oh. And so I was always, I like to use a subcuticular closure and no staples, no stitches. For my primary knees, because they tended to have good skin, good soft tissue, and it was just watertight from day one. Patients like it too. I mean, they don't like getting staples taken out.
So you did that. Okay.